Welcome to this ANROWS webinar. Today we're going to be talking about working with women who have experienced complex trauma in mental health and refugee services, a comparative discussion. My name is Michelle Robinson. I'm the Director of Evidence to Action in ANROWS. I would like to acknowledge the traditional owners of the land across Australia on which we meet today, and on behalf of ANROWS, pay my respect to elders past, present and emerging. I also acknowledge and pay respect to Aboriginal and Torres Strait Islander people who are viewing and listening to this webinar today. I would also like to acknowledge the impact of COVID-19, particularly on women who are survivors of sexual violence, domestic and family violence, and for those frontline services who are responding and supporting these women. Today's webinar will explore the findings of the recently published ANROWS report, A Deep Wound Under My Heart, Constructions of Complex Trauma and Implications for Women's Wellbeing and Safety from Violence. The research focuses on women with experiences of complex trauma and highlights the way that lived experience of complex trauma can intersect with gender-based violence, including domestic and family violence and sexual assault. The research was led by Associate Professor Michael Salter and co-authored with Elizabeth Connery, Molly Dragowitz, Jackie Burke, Jane Usher, Warwick Middleton, Sherelle Valencia, Beatrice Martin Monzon, and Kaya Noack Lundberg. I'd like to introduce the panel. We have online today Michael Salter, Associate Professor at the University of New South Wales, Scarlett Franks, Complex Trauma Survivor and Mental Health Researcher at the University of Sydney, Karen Williams, a Consultant Psychiatrist with the South Coast Private Hospital, and Amy Burkett, who's the Manager of Clinical Services at the Queensland Program of Assistance to Survivors of Torture and Trauma. Welcome, everybody. Just before we begin the panel discussion, I'd like just to let the listeners know that we'll have a brief presentation by the members of the panel, and then we'll have a live Q&A at the end of the panel discussion. So I'd like to encourage everybody to send through questions, clicking on the blue icon on the top right-hand side of your screen, and it'll take you to the question box where you can submit your questions. So it's a great pleasure to introduce to you all Michael Salter, Associate Professor at the University of New South Wales. Hi, Michael.
Hi, folks. Thank you so much for joining us.
Michael, you've been working in and researching complex trauma for many years. What inspired you to undertake this particular topic, and what were you hoping to address?
Yeah, look, my work in complex trauma goes back, really to my university days. A very good friend of mine is a complex trauma survivor, and so, I watched really closely as she tried to, access help through mental health and law enforcement, and intersecting with all different sorts of services, and often getting really poor outcomes, and ultimately, she was only able, I think, to find a good life for herself through her own sort of perseverance. And it just raised so many questions for me about why it is that people with histories of, child abuse and domestic violence and so on, particularly where that abuse and violence has resulted in sort of long-term chronic impacts on their mental health, why it is that so often they're not getting their needs met by current systems and current services. So that's really what prompted this project. It was a chance to look at complex trauma through the eyes of the women who experience it and ask them, what it's been like when they've gone out to look for help, and also, what's the kind of help that they want. And then we were lucky enough to interview over 60 professionals who work in complex trauma to hear their experiences of working with women with complex trauma too.
And I guess at the outset, it might be really useful to start with a definition of what we're working with here. What do we understand complex trauma?
So complex trauma is generally understood to have two aspects to it. So the first is the experience of violence and abuse that is repeated and normally often committed by someone that you love or care about and you're dependent on. And so it's repeat experiences of violence and abuse, often characterised by feelings of betrayal and powerlessness and helplessness. And then the second side is the impact on someone's health. So complex trauma then has quite particular impacts on people's mental health in terms of things like depression, anxiety, hypervigilance, emotional regulation, dissociation. It can show up in a myriad of different ways in terms of their mental health. And we also see impacts on people's physical health. Complex trauma has long-term implications for people's physical health. And then their psychosocial function, their capability to enjoy their life, to parent, to be in relationships, to work. So it has this dual aspect in terms of the sorts of abuse that people experience and the kind of impacts that come from that abuse.
And in terms of really high-level findings, were there some that stood out for you?
Look, I suppose what stood out for us was just how difficult it is at the moment in the Australian system for women with complex trauma to get all of their needs met. Very often it took a lot of perseverance from women in order to identify a professional or an agency that was trauma literate or trauma specialist. But even once they were with that agency, they often had needs that couldn't be addressed by one service or one worker. They needed to go out to other systems. And that was very fraught. It was fraught for the women, and it was also fraught for supporting professionals because they really couldn't trust that the woman would experience continuity of care and continuity of trauma support outside that setting.
Thanks, Michael. And I'd really like to unpack some of those findings with the rest of the panel. Turning to you, Scarlett, you're a survivor of childhood trauma, and you're also a researcher at the University of Sydney in the Faculty of Medicine and Health. As Michael's discussed some of the high-level findings, one of those was the effect of the difference in understanding that women who have survived complex trauma and professionals have of what complex trauma is, Specifically, it found that professionals favour psychological, biomedical,
It's important to consider the temporality of complex trauma, first of all. So because it's chronic or repeated victimisation, while people can certainly recover, the idea of a linear recovery journey where you return to an original pre-trauma state of being doesn't resonate for me and for many survivors. Recovery isn't so much a destination as a state of being that with support you can learn to occupy more and more over time. And that's something I'd really like clinicians and services to recognise more. The next thing is that complex trauma is relational, as we've said. So it often involves betrayal and violation by the very people who are supposed to love and care for you, like your parents or your partners. So we all have different parts of self. But if you've had to survive betrayal and violation and maintain attachment to the people betraying and violating you just to get your basic survival needs met, then it often happens that some of those parts of self have to be submerged and siloed off from others just for your attachment system to operate at all. And that's really important because services need to cater to survivors' disorganized attachment styles and experiences of dissociation, and also restorative attachment experiences that honour the different spheres and protective adaptations of different parts. And I think it's really vital to keep this in mind when you consider that survivors often have this chronic, deep-seated shame, and it can manifest in ways that just really baffle mainstream services. So you might have a survivor who appears to continually wind up in unhealthy or abusive relationships. And if you're not, fully across the relational dimension of complex trauma, well, this person just doesn't want to get better. Doesn't want to be free from violence. And then the last thing I'd say is that complex trauma is somatic. So it has these physical and physiological impacts that cannot be underestimated. And services need to address symptoms that women experience, like chronic pain, functional seizures, digestive and menstrual problems, paresthesia and fatigue. But even when you're treating the psychological, the emotional and the relational impacts of complex trauma, I think people need to bear in mind that even the brightest, most proactive survivor cannot exert their will over their limbic system. We need bottom-up approaches that work with our nervous systems.
Absolutely. Thanks, Scarlett. So, touching on the temporal, the relational and the somatic impacts and understandings. I'm going to turn to you, Amy. We have the findings show that not only are there differences in understandings between women and the professionals in space, but also between the professionals across the sectors, including health, refugee, child protection, and these all reported different understandings of complex trauma, which is, normally and obviously reflected in their practice, responding and addressing to complex trauma. The refugee sector, however, was identified as a leader in best practice frameworks. As the manager of the clinical services at Queensland Program of Assistance to Survivors of Torture and Trauma, Amy, could you unpack or describe to us how your service understands complex trauma and how this is reflected in your practice?
Yeah, sure. Thank you. So I think similar
Thanks,
to what's
Amy.
been mentioned already, but I think too what's different for us in the way we understand and conceptualise complex trauma is a broad understanding that actually, the refugee experience is likely to result in a complex trauma, response. So, for example, it's what's core to it is there's, persecution, oppression, violation of human rights. So all of that, leaves the victim, fearing and feeling helpless to prevent recurrence. And this can be over, long periods of time, and the trauma associated with displacement, so fleeing, leaving your home, due to persecution, state-sanctioned violence, torture, deprivation, separation from family members. All of that is what we kind of encompass into how we in this sector would understand complex trauma, is that someone is likely to have had multiple experiences prior to arrival, and then it can often be compounded by settlement, or having uncertainty, still going through the asylum seeker process, prior arrival trauma then continues to be compounded. So how do we then incorporate that into practice? I guess the first thing is understanding that there's multiple levels to it. There's a complexity to it. But I think one of the key things is really validating and normalizing the experience and the reaction, and very much kind of what someone is likely to have experienced prior to arrival. Their reaction is completely normal, and that, really needs to be understood and validated. I think it's too, it's really about kind of work and practices, as Scarlett just mentioned as well, that, address kind of all the different impacts, but really kind of underneath that is, enhancing control and choice, establishing and maintaining safety, processing the experiences, reducing fear and anxiety, restoring attachment and connections, and restoring dignity and empowerment, and reducing shame and guilt that often has occurred as a result of those experiences. Thanks,
Amy. And again, that, sort of shame and guilt has come back up. And I just wanted to take a moment to say thank you to the panel for the time, but in particular, thank you to you, Scarlett, for sharing your personal experiences. It really is greatly appreciated in the context of the webinar and what we're talking about.
Thank you. It's a pleasure to be here.
Karen, just following on from Scarlett and Amy, you're a private psychiatrist working with, or a consultant psychiatrist working in the private sector with women who've experienced complex trauma. This is a really interesting area. We've heard from the refugee sector and service from Amy. How do you work within the medical model to support women who have experienced complex trauma?
Thanks, Michelle. Look, the current medical model, I have to say, it does present some challenges in working in this area. Firstly, to start with, we have a very narrow definition of what constitutes overemphasis, I believe, on the actual traumatic event and focus on that. But in my opinion, I think that we really need to be focusing a lot more on what is actually happening to the body, the biological changes that are not just a life-threatening event. You can get, the biological changes from non-life-threatening events such as neglect, or if you have a parent that's frequently intoxicated and passed out on the floor, whilst you might not feel your life is directly, endangered at that moment, it causes the same response that any other trauma, like a physical trauma can result in. I think that the fact that we're not recognising how many things and day-to-day things that can happen to children result in the trauma syndromes, such as complex PTSD. And, if we don't see it, we then don't understand when we get these responses from people. You've got so many people with these horrible backgrounds, and then they are constantly feeling, all these, feeling angry and distressed, but they don't understand why it's there and what happened to them to result in those symptoms. I think that, that's one of the things missing with our current system. So in my work, I suppose what I tend to do is really try to empower women to understand what is happening to their bodies during, what has happened to them during their past, but also how that replicates in their current life. And I find that when women understand their symptoms as a product of their childhood, they feel a lot more empowered, and they feel that they can do something about it. Mm-hmm. So I still do use the medical model. I still, explain the chemistry of what's happening to an individual. And I think that women feel a lot more hopeful, because when you know what's causing the symptoms, they're not so frightening. So many women are afraid of their symptoms, and they feel like they're going crazy. Why am I so scared just to go to the shops? They don't understand that their fight or flight mechanisms, and that's putting it simply, is turned on at lots of different things, not just when they're immediately at risk. So much of it is validating how their past has resulted in their symptoms, and actually sort of telling women or explaining to them how actually their bodies have worked very, very well, and that some of their symptoms have been adaptive, and that they've developed things like dissociation, for example, to help them survive, and that it's not a sign of them being unwell, but it's just a sign of them having been injured.
Mm-hmm. And this goes back to some of the symptoms that Michael was referring. is how trauma histories are understood by the health system and whether or not there's a gendered response to these histories and the care options available to you as a treating psychiatrist.
Yeah, so the current model, I think we have this focus on the sum total of an individual symptom. So a person who turns up and if they're sad and they're not eating properly or not sleeping properly, got no motivation, we go, we look at that pattern and we say you've got depression. Or if you've got issues with self-harm and you're angry and you're impulsive and your relationships are falling apart, we look at that constellation of symptoms and say, you've got a personality disorder. The actual things that happen to the individual to result in those symptoms, and some clinicians may touch on, but not all of them. So the trauma is almost like an incidental finding. They did have that in their life, but it's not a main driver of what has caused their mental illness. So we sort of think of a lot of mental illnesses as just springing up out of nowhere. There's no real cause for it. It's just turned up out of nowhere, and so we focus on treating those symptoms, with medication rather than looking at the drivers of those symptoms, understanding that those symptoms are part of the trauma response and actually addressing the trauma. So you asked the question, is it gendered? Well, absolutely it's gendered. We're just talking about the checklist of symptoms people have. And if you think about sort of like the emergency room, for example, and if a soldier were to walk into the emergency room drunk, angry, if he'd been, playing chicken on the road, the moment they were told that you're told that this is a soldier, we immediately think this guy could be traumatised. We immediately think that something he's experienced in the past has given rise to the symptoms that he's got. And we respond to that quickly. We straight away recognise it. We look at that and we say, okay, this person's been really badly impacted by what's happened to them. So we write letters saying no more deployments for that particular soldier. We say you need to have trauma therapy. We offer a range of things to deal with what's happening to them. And then you look at things that we know for a fact, that say every 20 to 30 minutes the police are receiving reports of a sexual assault. Every 3 hours a woman is hospitalised because she's been assaulted by her partner. Think about the fact that there are 72,000 women who are made homeless because of domestic violence. How are we not recognising that any woman that walks into the emergency department intoxicated, angry, wanting to... We don't immediately go, she could be traumatised. What we immediately do is think, she could have a personality disorder. We should be immediately thinking that any woman that walks in with those kind of symptoms could have a history of trauma too. It should be the same response because those risks are very, very high. And if we do that, if we can start seeing that immediately, we can start responding immediately to that as well. And I just don't think that we're offering traumatised women anywhere near the level of service that they need. And as a result, we've got so many people suffering, I think, needlessly. Because when you do treat the trauma, and this is from my clinical experience, I see fantastic results. People become empowered and being able to lead productive lives, which is ultimately what we want. So perhaps we need to be looking at some change or some emerging models of care. And we might thank you so much, Karen. That's been a really, really useful picture of what's happening in the mental health system. And we might come back to a question which we've got through the audience in terms of models that could be looked at in this context. Michael, I just wanted to come back to you and offer you an opportunity to comment on the gendered responses to complex trauma, which is something that you did find in the report.
Yeah, I mean, Karen's point's really well made. Unfortunately, we have these quite pervasive cultural stereotypes about women and mental health and sort of quote unquote kind of crazy women. And that women were kind of falling into that kind of cultural trap in a range of sectors. If they weren't seen to be presenting, quote unquote well or properly, then, they were very likely to receive a kind of a trivialising or dismissing response. And unfortunately in Australia, and I think overseas, we've seen this division in trauma studies and trauma treatment, where trauma that is adult onset, so trauma that might occur over the age of 18 in the context of war, or, car accidents or workplace accidents, those responses are funded, those responses are embedded in hospitals, they're widely accessible, and preferentially speak to the male dominant experience of trauma, which is adult onset trauma. And I'm not marginalising boys' experiences of trauma, but complex trauma, which we've known or we've had a clear picture of, really since the late 70s has been neglected. Very, very difficult to access specialist complex trauma care. And unfortunately, we're not seeing the mental health workforce through the university system being adequately educated in trauma and complex trauma, so that when psychologists and psychiatrists are going out into the field, they're equipped with the skills that they need to identify trauma, let alone treat it.
And this segues nicely into some of the recommendations for policy and practice that you've identified in the report. What do we do about it? Like, how do we improve access to comprehensive treatment under our existing policy arrangements?
So I think it's crucial that we identify and prioritise trauma and complex trauma as a public health problem. And at the moment, trauma and complex trauma is somewhat invisible in the mental health conversation. We've talked a lot as a country about depression and anxiety, and trying to normalise help seeking and promote early intervention. And we've also seen initiatives there around early onset psychosis as well. We need a government commitment to identifying and healing trauma in this generation, and then there's a number of sort of flow-on effects from that commitment. We need a mental health workforce that is skilled in trauma, and I have tremendous respect for my clinical colleagues, but at the moment trauma is, despite the very, very high rates of complex trauma across all psychiatric populations and all psychiatric presentations, trauma is a voluntary specialisation, and what it means is that the mental health workforce as a whole is unable to meet the demand for services. And then we need to think about models of care. We need to think about how we create systems and services that are friendly and welcoming for people with complex trauma and that deliver them a comprehensive service that enables them to recover in whatever sense that means to them. And if we don't provide those opportunities, then this group is very high in their healthcare utilisation because they have high needs, and when those needs are not met, then they are liable to present again and again and again and again. And so, from a purely economic perspective, neglecting people with complex trauma is a very expensive proposition, and we would save a lot of suffering and a lot of taxpayer dollars if we simply worked with women with complex trauma to meet their needs.
And across a service system that was a little more joined up and coordinated. And I'm going to throw this open to Scarlett, because Scarlett, you've had personal experience in accessing support for complex trauma. What barriers did you face? And also, what worked for you, and what changes would you advocate for?
Thanks, Michelle. I think maybe the best way to illustrate the barriers I've faced is to say that the vast majority of services I've accessed had never heard of trauma, let alone complex trauma. And if they had heard of complex trauma, it was because it was their exclusion criteria. the service. So there's just the fact is that even if you find someone sympathetic or who has gone out of their way after their education to specialise in trauma, like Michael was saying, there's just nowhere for them to refer you to most of the time. And then the financial and bureaucratic barriers are exhausting. Like women with complex trauma having to navigate systems like NDIS and Medicare, victim services, Centrelink, the National Redress Scheme, and public housing. And these systems can be so demanding and punitive that you just become worn out and give up. And, you know, your therapy can't really get down to the bottom of things and support you to heal from trauma if it's just crisis management, because you don't have any kind of baseline safety and financial security. Part of those financial barriers is the way that our system favours biomedical and cognitive behavioural treatments over psychodynamic and somatic. So sometimes when you do find a clinician who is trauma and dissociation informed, often they are a psychotherapist or a counsellor, and they can't be accessed under Medicare, or it's very hard to get funding for that ongoing care. What's really worked for me is complex trauma specific care. So after a 2-year wait list, after 7 suicide attempts, I finally got to the top of this list for Westmead's psychotherapy program for complex trauma, which was really life-changing. It uses the conversational model and also has a lot of clinicians trained in trauma-specific services like EMDR and somatic therapy. And it was integrated with an outpatient youth psychiatric program that provided case management, psychiatry, occupational therapy, and psychology, and different services all sort of under the same roof. So that was excellent. The difficult thing was I was on a wait list for this outpatient service at the age of 14, and I didn't get to the top of it until I was about 23 or 24, which meant I only had 2 years left of eligibility because it was a youth program. So it's just so these programs that do exist are just maxed out, but they work. And I think the other thing that has been so vital in my healing and empowerment has been peer support and finding community. So there's been some private outpatient group therapies for complex trauma that have been the places where I've made lifelong friends and found a sense of meaning in all of this. And I would love to see public funding for access to those kinds of groups for women.
Wow. And so to your understanding, is it still the only facility available was that in New South Wales? What was the sort of regional boundary of where you were looking?
So I was looking in New South Wales, and the regional boundary, the regional boundary for me was just as much petrol as I could afford. There's been, I have never had a commute to therapy that was less than 90 minutes. And there was a period of my life where I was commuting 3 days a week to a private psychiatric hospital for outpatient care, 2 hour, 15-minute drive each way. And I live in a metropolitan city. I live in Sydney. So I think that just highlights and the lack of sort of care coordination, because I had to seek out all of these services on my own. I had to be persistent and proactive. Even one service that I attend now for group art psychotherapy and group interpersonal psychotherapy, I discovered this. This is a fairly new service, and I discovered it because I had Google alerts on my phone for complex trauma Sydney.
Wow.
And I'm often having to go into my GP or a psychiatrist and educate them and refer them on to, the Blue Knot Foundation or other big bodies where they can have a little bit of a read about complex trauma. And I take no pleasure in doing that because it means that, we can't work together.
Yeah, and I'm going to ask Karen just to step in here for a moment. Given just to comment on that lack of service, and as you say, Scarlett, you're living in Sydney and you're having to travel these really long distances to one service and wait an inordinate amount of time to get to the top of the list. Karen, are there other services available that you're aware of, or is it just the fact that there are none?
Well, I think there's the fact that trauma is so invisible in our society, and that there's that idea that we have to just medicate the symptoms away and not address the whole person, everything around that person. So it's not enough just to manage anxiety with anti-anxiety medication. If the person is going home to a place that is not safe and that they're at risk, you can't send someone onto the street where they've got no money and they've got no support and say, I don't know why you're not happy, I don't know why you're so anxious. You have to address all the aspects of that individual's life, and I think that's really what's missing. And I've been very lucky to be working with the Illawarra Women's Health Centre, and we're in sort of the design phase, trying to establish a trauma centre which recognises that women who have these histories of trauma need a whole range of services, and it's not just counselling, it's not just medication, but it's also financial support, legal support, parenting support, social support, all of those things that currently women have to, if they're lucky enough to access, and it's not everyone that even can, they have to go to multiple services, and as you just talked, wraparound service where you can get all of these things that you need, to address the person as a whole, I suppose, and so that's something in the pipeline. But yeah, there's nothing like that out now, and I think in 2020, why isn't there something like that? Why isn't it possible for women who are traumatised to just be able to go to one place and easily access what's needed? And I think the advantage of starting to recognise it, and clinicians and all services, I suppose, recognising trauma, is that we can actually start to see how huge this problem really is, and maybe incentivise the justice and police system to police it better and respond better to crimes against women.
Yeah, so we'll look forward to hearing what happens with the proposal to establish the New South Wales Illawarra Centre. That's the health centre that's looking at this.
Well, there's quite a number of people involved in it. But the idea has sprung out of the Illawarra Women's Health Centre. There are amazing women working behind the scenes to try and get this, actually to become a real thing. And we're in the design phase. We've got some financial commitment already from the government, so it's looking promising. But it's just such a hard slog for something that should be already out there.
Yeah, and you're doing it on top of your day job. And Michael, you've had something to do with this as well, I understand.
Yeah, it was probably a week after we finished drafting this report, and Sally, who heads up the Illawarra Women's Health Service, got in touch, and we had a meeting And it was quite funny because, she's proposed this sort of comprehensive, holistic wraparound service, which was exactly the conclusion that our project came to, is that we need these one-stop shops for complex trauma, for women to go where their needs are being met and addressed. There's specialist care, it's flexible, and it's not required, Scarlett said, to drive, many hours a week, sometimes in crisis, sometimes managing, child protection, and it's been a really exciting kind of move forward, and we're really keen to use this research to articulate the importance of the model to government. The trauma-informed care paradigm has been driven by frontline workers. It's been therapists and psychs and social workers and workers at the front line who know the realities of their clients that have been pushing trauma-informed care now for decades. And it's past time that government listened and that government met people halfway and realised, this is an issue whose time has come, and it needs investment in specialist services. So we're really keen to use the current parliamentary inquiry into family violence. We'll be drafting a submission based on this research, actually, and really trying to get complex trauma onto the agenda as a critical part of the health and safety picture when we talk about family violence.
Great. It's great that the research has been able to provide that as the evidence base. And I'd also like to acknowledge the work that you do, Scarlett, as a survivor advocate in promoting what needs to be done and based on your own experience. And turning to you, Amy, because the report does identify the refugee sector as providing best practice in terms of complex trauma services. I'd really love to understand a little bit more about the broader organisational frameworks that allow for programs to meet the needs of survivors, of people who have experienced refugee-related trauma. And is this something that the models for change could pick up on going forward that have been discussed by Scarlett, Karen and Michael?
Sure. Thanks, Michelle. I think one of the, first things as well is kind of for us in our work is acknowledging that, while the, refugee experience, is likely, the trauma experience is likely to have, an enduring psychological impact on survivors, we do know that not all are going to go on to develop mental health needs or concerns. So it really then becomes about kind of understanding, each survivor has different recovery needs. So the way that we kind of incorporate that is then understanding that, trauma impacts, as we've all mentioned already, the relationship with the self, with others, and then the world around them. So interventions actually need to occur at all those different levels. So some of the services that we kind of have to try and address that sort of thing is, so at a therapeutic level, yes, there's that kind of individual couple therapeutic component, but also we know, again, as everyone's already highlighted, we still work alongside mainstream services. So there is advocacy still needed, with the health system, the mental health system, child protection, all of that. So we kind of understand that, and that gets integrated within those roles, I guess, then as well, to support people recovering based on kind of what their presenting needs are is, also offering kind of group work, youth activities, different social activities, community development, capacity building with other services. The other thing probably, as everyone's kind of already mentioned as well, is understanding and recognising some of the barriers to engagement. So, for example, with our cohort in particular is around, utilising interpreters. So the language barriers that can occur. So, reducing that and using interpreters. Our clients are able to engage with us for as long as needed. So we don't have any kind of capped session amount. So, if someone needs to engage with us for, 8 years, then they can if that's what's needed. Or, some others, it might only be a few sessions, but it's around what the support is. And it's, our service is voluntary and it's free, so clients don't have to pay for the service either. The other thing too, I think, as we all know, with the way complex trauma can present and recovery needs, we're also not limited in when people can access our service. So someone might have arrived last week and they could refer or self-refer, or it could be in 20 years' time when something else has kind of come up, triggered, and then they need support. So no limitation around that eligibility of when someone could access support as well, because it can be at any point, and people need to come in and out of the service as well. Do I think some of that could be implemented in other services? Yeah, I absolutely do think so. And I think there's a lot to kind of, again, sort of, there is that sort of often sometimes that siloing or that fracturing that happens between services. And so kind of, collaborating and understanding what's needed and trying to reduce some of those barriers, I think would be really beneficial for all clients, regardless of their background.
Great, thank you. And definitely saw an absence of some of the barriers that, for example, Scarlett was referring to earlier in the model. And your service is funded federally and through state and territory government, through the state government?
It is, yeah. So we're part of, a national network of services, and so there's kind of one of us in every state and territory. But yes, we're funded Commonwealth and state-based as well.
So a good sort of coordination across jurisdictions. Well, thanks, Amy, and thanks to everybody who has been sending in questions. We've got heaps, which is great. And I'm going to throw to questions now because we're going to have sort of the last 10 minutes or so of questions from the audience. One of the first, and I might start with you, Michael. In practice and research, we hear a lot about vicarious trauma, but what about vicarious resilience? Can you explain what this is? And if any of the other panel members would like to also address it after Michael, that's cool too.
Yeah, so
vicarious resilience.
Vicarious resilience. So this came up for us in the research because we were asking professionals, particularly about vicarious trauma, which is the well-known negative impacts and effects of complex trauma work for people who are, consistently exposed to traumatic material, that they might also come to exhibit some of the symptoms of traumatized clients. So we were asking professionals about this, and we had someone say to us, I'm so tired of people talking about vicarious trauma. And she said to us, I love my work and I get so much from it. And she said, what about vicarious resilience? And we thought, that's interesting. What and from the client, they learn from the client resilience, they learn from the client. Doing the work, we had people say, I've done it for 40 years, I'd never do anything else. I love working with this group. And it just really struck us that sometimes our conversation as professionals about complex trauma work really harps on the risks and the impacts we have to work with. And it's really important that our internal discussion amongst ourselves about complex trauma work actually acknowledges why we do it, which is that we really enjoy it, and there's something very profound about this work. So, that concept of violence is really powerful in calling our attention to actually the beneficial and meaningful aspects of trauma work.
And Karen, is that something, and Amy, as professionals in the sector, is that something that you've experienced or as part of your your networks and with other professionals?
Absolutely, for me, Karen speaking, I love the work that I do because the population that I work with, they are so motivated. Once you explain to people what's happening to them, and you let them, really understand what their symptoms are, what it reveals about them, they are the most active patients that I have, and I see patients getting better. So I think for any doctor, that's what we like to see. When you don't see people as just a sum total of their symptoms, but as a product of, their entire life, you get so much more out of it. You really get to know your patients really, really well, and you become very involved with their lives, and you develop really special relationships. And then when you watch women standing on their feet after years of being suppressed and abused, it's beautiful to watch. What's not to like?
Yeah, Amy here, I agree. I think the work is incredibly rewarding. I'm often completely blown away by sort of what women have experienced before arriving, and can just sometimes just shrug it off as, yeah, that's just life. That's just what I've been through. And I just find it tremendous, the endurance and the resilience that they come with, and then that interest to continue to kind of, support those around them or others. I think too, there's also, what keeps me in this work is the level of compassion that peers have and other people in this work have. It's really lovely that, there is this, real interest and passion in the work. But I get a lot out of the work as well.
And Scarlett, you're in the sector as well as a researcher at the University of Sydney, examining adaptations to trauma through co-produced research. How do you respond to vicarious resilience? What do you experience?
Thank you. Well, when you're a client or a patient, you can feel that. So on the one hand, if you're going through this revolving door mental health system where you're not getting the support you need, you can feel a kind of a mutual hostility, between you and the dozens of people that assess you and try to treat you over the years. But when you finally get support, appropriate care and support, that's the satisfaction is mutual. Like, I can tell that a clinician is getting something out of my company because it's mutual. We're creating this meaning together. This kind of intimacy that we create is the antidote to the shame that complex trauma brings up for people. So I feel like it's in my experience as a patient or a client, and then it's also in my experience as an advocate and a researcher, because I couldn't. The best people I've ever met have been through some stuff, and they've gotten through it not because they're better people than those who haven't survived, but because they've leveraged the luck that they have been fortunate to receive, and then as soon as they start to get better and lead healthier, more fulfilling, safer lives, they pass it forward. So I'm just seeing that is awesome.
Yeah, great. Thank you for that. We've got time for a couple more questions, and this one I'd like to touch on very quickly, and it's something that you raised earlier, Amy, about advocacy. But I think I might throw it to you, Scarlett. Would getting an advocate be a good way to help with women's experience of complex trauma? Would getting an advocate be a good way to help women with experiences of complex trauma navigate a single-issue, fragmented service system?
Thanks, Michelle. I think that it really depends what an advocate means, because that could be fantastic. As we've said, the different systems and agencies and funding providers that you have to navigate to get the care you need. It's like attrition warfare. It just wears you down and really can re-traumatize people. So having someone who's across all the different services that are available and can help you with things like the paperwork would be fantastic. But I guess I am wary of how that advocacy would be set up, because we don't want to create yet more paperwork for women to do. We don't want to create yet another separate service. So going back to what Karen and Amy have spoken about with best practice models, it needs to be integrated across all the different systems providing for women.
Absolutely. I think that's what the basis of the report is, holistic, integrated responses. Did Karen or Amy, did you want to comment on that?
It's Amy. Not overly. I mean, I think exactly as Scarlett's kind of said. I mean, yes, we kind of integrate that into our work, and I think where some of the gaps where I think it could be really useful is kind of more of that care coordination, because I think sometimes clients can feel really isolated in that process around where to reach out to, what to do. So, more kind of, how can that be better supported, and maybe it's more from a service point of view around, better collaboration or crossover, so it's not actually left to the survivor to be navigating that as well.
We have room for 2 more questions. One to Michael from the floor, which reads, Michael, hang on, it's just coming up. Sorry, we've lost it. Thanks for the wonderful discussion. I am both an academic and a person with complex trauma. I have a question for Michael. Can you speak to how your gender shapes your own positioning within this research on women with complex trauma, and how you reflexively unpack some of the issues that invariably come up around men who do research on women?
Sure. I mean, it's sort of hard. It's a difficult one to answer. I mean, a few reasons. I mean, complex trauma is sort of something that happens to you. It's not really something you choose. And it's true as a researcher in complex trauma. I have to say, I've been both a child and an adult in many circumstances with women with complex trauma, and I think, continue as an adult to kind of model, I guess, a partnership approach, as a professional where, my work's very much done with women with complex trauma. It's not sort of done to women with complex trauma. And the gender dynamics are not straightforward in complex trauma. I've had women nominate for research and say to me, I wouldn't speak to a female interviewer because I wouldn't want to re-traumatize them, or because they might resent the fact, they might feel as though their mother was non-protective, and so there's a whole set of issues for them about, trusting a woman with some of these narratives. So I think it's always kind of a complex piece. I will say as a researcher, one of the nice things sometimes is, having an interview with someone where a lot of their experiences of men has been pretty bad. And, it's a 1-hour interview, but it can have a kind of a reparative dimension to it when it's just it's warm, there's a rapport, there's trust. There's not a lot at risk because they don't have an ongoing connection with me. It's a 1-hour sort of interview. But yeah, I think there can be a nice kind of aspect to that where, a sense of, okay, like not all men are bastards, like, and also that men can listen and do this work. And I do want to say I work with a lot of male clinicians who do excellent complex trauma work. And there's a lot of men in the field who are very effective at doing this work, as men. And that's not to say that gender's irrelevant, but just that it's a sensitive, complex issue here.
Yeah, absolutely. Thank you. And I've got we've got time for one last question, and I think this is a really critical question given the nature of complex trauma, and it's to the panel from the audience. How do we encourage those parents who experience complex trauma to take responsibility for their children? Scarlett, would you start with the answer? You've all got 30 seconds to wrap it up on this one.
How would we? I think it's really key to know that complex trauma is intergenerational, and so parents, the non-violent parent is often reaching out as well for their own support, for their own healing, and helping them, to better manage and to process their own complex trauma history can be one of the greatest gifts you can give to their children. And for myself and most of my friends, one of the big reasons that we persevere with this exhausting work of recovery is because we're aware that whether we become parents ourselves or not, our complex trauma can affect others in ways beyond that, in ways that we don't choose. So we want to heal that so that we're not transmitting it to the next generation.
Thank you. I think that just sums it up so beautifully. Karen and Amy, I'll start with you, Karen.
Yes, I think that's a rather loaded question. There's a bit of an implication there that women with complex trauma aren't trying to take care of their children. And I think that if we want that, if we want women who have been traumatised to take care of their children as a society, then as a society we need to respond to those women first and foremost, that we have to start protecting women from violence and not let this happen to begin with, and recognise it early and support families, from the get-go. It isn't enough to put all the responsibility back on them and say, well, we've let you be abused by your family and done nothing about it, and we've let you navigate a health system that just completely ignores you and do nothing about it. We've let you report all of the these assaults on you, and we haven't done anything about it. But now that you're experiencing all these horrible side effects of that, you've also got to take responsibility of another human being and do that without our support. So I think if we take responsibility first, you will see that flow-on effect, because my experience with women who are traumatised, the last thing they want to do is damage their children, and they do everything they can within their power and what they know, and remembering that they often haven't had good examples of parenting. So within reason, they are trying their very, very best, and I think encouraging that and supporting that is the most important thing.
Thanks, Karen. And Amy, how would you respond to that question?
Yeah, I agree. I think that there's a lot you could answer, but what my brief response would be is, what I probably always try and keep in mind is, because of the intergenerational impact, is any intervention that you're providing to support a survivor, it's going to have an influence on a future generation. So, I think even sometimes if we can get disheartened, say, in the work that we might be doing with someone, keeping in mind that maybe that's going to have an influence down the line. So, any support and any work we can be doing now will hopefully have an impact to sort of support future generations and lessening that transfer of the intergenerational trauma.
Absolutely. And I'm going to close with Michael's comments on the intergenerational nature.
I think it's such an important question for us. I mean, I absolutely take Karen's point that simply because a parent has complex trauma, it doesn't mean that there's issues with their parenting. There's lots of wonderful traumatized parents out there. But, in terms of the public health crisis, when we look at mental health, physical health, complex social problems, what we find is that complex trauma is at the heart of so many of them. And the reason why those indicators have been so difficult to shift and improve is precisely because we ignore complex trauma. And what it means is that our investment in complex trauma care now pay so many dividends for future generations. We just need to make that commitment now. Complex trauma stops now, and that's our responsibility. That's not survivors' responsibility. And at the moment, and we've really heard that through Scarlett's just incredibly articulate biography of her own experience. At the moment, the onus is on survivors. And it is up to the rest of us. It shouldn't be left to survivors to take carriage of this and to resolve this once and for all.
So expertly summed up. Thank you, Michael. Look, I absolutely commend the report to everybody listening, and much more broadly. I'd like to thank the panel for sharing your experience, your insights, and your knowledge. It's such an important issue, and you've just given so much for us to think about. And I'd also like to thank the audience for tuning in. The webinar will be available on the ANROWS website, and we have a list of many more questions which we will circulate to the panel and look at where particular themes can be responded to, because there are a few there, and make those available as well with the webinar recording. The research report, A Deep Wound Under My Heart, Constructions of Complex Trauma and Implications for Women's Wellbeing and Safety from Violence, is already on the ANROWS website, and you can download both it and the Research to Policy and Practice, which is a summary of the key findings and implications from the website. So I'd like a big heartfelt thanks to the panel. Thank you to the audience. I think it's been an incredibly important conversation, and you've really helped us explore the impacts of complex trauma and what some of the responses might be to addressing it in terms of domestic and family and sexual violence. So thanks, everybody.
Thank you.
Thank you.
Thank you.
The next webinar from ANROWS is on Monday, the 22nd, where we will be discussing an integrated response to working with men who use violence in the justice system, exploring the South Australian model. So if you'd like to visit the ANROWS website for more details, you'll find them there. And to sum up, I'd just like to say thank you again. I'm Michelle Robinson, and on behalf of ANROWS, thank you and goodbye.